Okay, I think I need Kathy Greenlee to come on up. Yeah. All right, this is the after-dinner conversation. And you heard earlier from Kathleen how lucky we are to have her. And I will say this as a preface. I'm a guy who works with text, as you can tell. Kathy is a eloquent speaker who can basically just go with the flow. So we're going to try this little conversation. I'm actually going to move to the chair, but I'm taking my notes with me. So anyway, we're going to have her kind of reflect a little bit on what Kathleen shared with us earlier this evening, and also some thoughts that she has about her passion and her work and what she wants to bring to the center and for the Kansas City area regionally, and then also for the nation. So we have been in conversation for quite some time about this, and we were delighted finally when we settled on a start date of November. We had a little rocky start. Kathy had an accident, a very serious accident, 4 days after she left HHS, and I got a call from Deb, I think, announcing we were supposed to have some conversations and finalize her appointment and get her start date set, and she was in the hospital with a serious injury, and I was heartsick and stricken with this fear that we were not going to be able to make this happen, but we were able to do that. Her enthusiasm hasn't been dampened, and she hardly missed a step, though she may be limping a little bit. She was taken up where she's left off in a remarkable stint in her leadership role at the national level. You heard Kathleen talking about bringing together both the Administration on Community Living and HHS Assistant Secretary work, and really transformed that agency through the work. She's dedicated her life to public service, and in the last 7 years has prepared her well for her return, hopefully what we consider to be the last chapter of her career in working with aging and disability through the eyes and the vision of the center, not only for this region, but for nationwide. We're going to spend a few minutes in conversation to give you a glimpse of just how enthusiastic she is about reframing this aging and disability question, and to really address the issues and the opportunities that exist within ageism and debility in this country. So the other thing I have to share with you is that we both kind of are policy wonky people. So we have these little cards that we created so that when she goes off on something for the next 10 minutes, I can stop her and she can do the same for me. So.
And we're both talkers.
And what?
We're both talkers.
I'm going to shut up and let you do it.
No, we're both talkers.
Okay, so before we begin, I wanted to give you an opportunity to share any remarks that you had about Kathleen's testimony to you, because I think that was probably the first you'd heard of some of those things that she said. So.
I have heard the story about me taking her to Washington, and I'll take credit for that. I think she was a fabulous secretary. So I'm not sure how long Kathleen was going to be here, if she's still in the room. But it's, I just want to thank her publicly. When Kathleen left HHS, she and I had worked together for 19 years. And it was a really big loss to me personally when she left. I can tell by my talking I'm going to need some water. I'm just going to give someone a heads up. Do you have some hiding over there? Ta-da. So I want to thank her publicly. And these are the kinds of words that anybody would love and hope to hear from someone who had been their boss, their mentor. But when that person's a former governor, former secretary of HHS, it's just doubly special. We did some wonderful work together when we were at HHS, and one of the things that was most important to me is she always had my back. And it was really important as I worked with a group of people to know that Kathleen would always be there, and she would buy into what I was telling her we needed to do, and was always there. But before we start our Q&A, John, I also want to thank you for helping me as I've started at the center and dealt with my injury. So we have doctors in the house, so I'm going to impress them. I have a level 6 tibial plateau fracture and a fractured ankle. And this is where you all, ooh, yeah. I was in the hospital a long time. And so we postponed my start for a month. And when I first started at the center, I started by coming to work in a wheelchair. So to all of my colleagues here at the center, thank you. They've seen me progress from the wheelchair to the walker to the cane, and I will get away from this cane eventually. John has helped me haul that wheelchair back and forth to home. You about ran me off the curb at one event, but otherwise you did pretty well. So I just want to thank you all for your support, because this has been a transition no one would have hoped for, but I'm thrilled to be here now. So let's start in.
All right. So tonight we heard from Kathleen of the Aspen's 5 big ideas on end of life, and you've dedicated your life to aging in the last chapters of life. So start to us by talking about the ones that captured your imagination, of the 5 goals.
So I brought my own show and tell, because I'm a wonk, as you say. So here's the book. I've read it. The first part of the book, the first thing, and Kathleen went through these, was a discussion about advanced care planning, which is very much in theme with not just the center's work, but the recognition of Nathan tonight. And you and I have talked about the fact that I have returned to this issue in my career about every 10 years, and it continues to change. We still need more Nathans in the world. We need people to do what Nathan is talking about in terms of filling out advanced directives. We need people to have the caring conversations that the center has talked about, and we need to keep that going. That's documented in this report as the first kind of request. Kathleen mentioned in passing also we need to work with employers, which is something the center has done in the past, to help make sure that this gets incorporated into the workplace. What I did not know and have learned since I started working at the center was that the advanced directives need an end point, that at some point they have to be converted to physician orders. And so the work that I've done with the TPOP project are transportable physician orders for patient preferences, and I know our TPOP people are here, that at some point you actually have an order so that someone's wishes are recognized. The piece in there, I like hard things, and the piece in the advanced directive section of the report that fascinates me is how do we systematize this work? How do we institutionalize it? We will reach a threshold of penetration through these other efforts. So how do we anchor it? So like Kathleen was talking about, when someone enrolls in Medicare, they have to fill this out. When they enroll in private insurance, they have to fill this out. You can make incentives through payment, but I don't know that that's what's needed. I think it needs to be just a routine practice. You fill out these other things, and now we need you to fill out this and make some decisions. So I think we can continue that work from section 1 of the report. Is completely in the sweet spot of what the center's always done. And I think some thought work on how we institutionalize it is sort of the next piece for us.
Okay. And I know that creating new models has also been a passion of yours, and a lot of the work that you spent these last 7 years in Washington was trying to bring together very different models in terms of the disability community and the aging community. So tell us a little bit about that work and kind of how you want to see that come back to Kansas City and really hit the kind of the real world in terms of the work that we're doing.
So delivery system reform is a big deal. They have I can't even remember the acronym. They would all call it by the acronym in Washington. And I would get frustrated because as the ACA passed, as we started to look at healthcare reform, community organizations were never in the conversation. Quite physically, I was not included in conversations. Our policies were not included in conversations. And I have a very comprehensive view of health and healthcare. It's not the same thing as medicine. That to help people have health at home, we need to talk about the services that also take place in the home. So we had been doing this work at the Administration for Community Living all around the country. How can we get a local social service organization to implement evidence-based programs, and how can they work with a hospital so when someone comes home, we can actually bill Medicare for meals? Or how can we help with care transitions? We've worked all over the country on helping this kind of integration, but it hadn't happened in Kansas City, and it's starting to happen now. You all had started conversations with David's leadership from Mark, with your leadership, with KU. We need to get all of the hospitals sort of in the conversation and talk about how do we really integrate so that community organizations can be at the table to help support people's health. Falls prevention, I've been asked to speak now about falls prevention by talking about falling off a ladder. I've become a new expert in falls prevention.
This was the second time she fell off.
I fell twice last year, and that was the secret.
Learner.
That was the secret part. So I've given up ladders. But falls prevention is a good example that we can identify people who are at risk, who have gait impairment, and figure out how to provide some support in the community. We can deliver those services. It doesn't have to be in a healthcare setting. We can do that with good quality, good outcomes, less cost. Oh, Don Berwick would be proud. Triple aim. So that's the wonky thing. You're supposed to hold up your wonky thing.
So I know language is important, and framing this issue is so important as we integrate into social support systems to help us demedicalize aging. So what final thoughts can you leave with us about embarking on this new journey under your leadership at the center?
So I'm going to back up and add something to your last question, then I'll answer this one because I'm not bashful. In the 5 sections of the report, that last piece that I was talking about, community, is the weakest section of this report. It's the physically shortest, and it's the most unformed. How do we tackle Medicare payment? How do we deal with quality, more training? How do communities do this work? Is unstructured. That's the space we should step into. This is where the center can provide real leadership, and this is sort of arriving at the right time for us to do that. I went to DC with particular passions. One of them is my commitment to working on elder abuse, we talked about. I'm doing a community presentation next month. There was a period in time that every speech I gave, and I've talked publicly hundreds of times, that I would stop and talk about elder abuse. 1 in 10 older adults will be abused. I would talk about elder abuse on topics that had nothing to do with elder abuse. I'd stop and say, and now we're going to talk about elder abuse, because I needed people to be paying attention. So I appreciate the opportunity to do that. I also want to continue to challenge and talk about being old and aging and ageism, and how we need to change the conversation in this country about what it means to be old. We did a White House conference on aging in 2015, and we did regional forums all around the country. So we went to Seattle and Boston, Cleveland, and we asked local political officials, politicians, to come speak. Every one of them made an ageist comment. Every one of them. They would be dismissive about how old their mother was. They would say something that was ageist, and it was just insidious. I mean, that we really have a culture that doesn't support age. So there was a project that started in 2014. There were 8 national aging organizations. AARP is among them, but they're not the only one. The Hispanic organization, lots of other organizations, got together and commissioned a study. How do we tackle ageism in this country? They contracted with an organization called the Frameworks Institute. So they came up with a report. It was produced in 2015. That's the base report. They produced a new report in February, and I read it this afternoon. And I told you I brought my cheat sheet. There was something in that report from today that I wanted to have all y'all think about. So here's my cheat sheet. I want you to think about what older people need. And just let that soak in. What's your concept of what older people need? Got it? Did you digest that? Now, I want you to think about what we need when we're old. It's a different conversation. Your thoughts went from outside of the room to inside of the room, from an abstract to concrete. When we talk about our own aging, that's what we need to do. If all of us would talk about aging in a first person and stop othering older people, like they're outside of here, we could actually change the way we deliver care, we could have the support we need in communities, and we could talk about the fact that we're all aging. My parents are aging, my sister is aging, you and I are aging. And what we need when we grow old is the right way to frame the conversation. It's the most positive way to talk about the fact that it's about us, it's not about them. No matter where you are, in terms of your gray hair or your bifocals, it is about what we need when we grow old, and the center has a big role to play. That's why I wanted to come home, why I wanted to join the center, because we're at the cusp of talking about really serious conversations at a really critical time in people's life, when they're aging, when they're becoming ill, when they're dying. What do they need? What do we need when we grow old? So it's wonderful to be here. It's wonderful to meet all of you, so I'm glad to be home.
Welcome home.
Thank you.
I know you've got big plans to engage a lot of folks. We've put her on a, I think we saw you less in March than
I traveled a lot in March.
She was all over the place. So Kathy's work will not only be locally and regionally, but she's got a huge role to play nationally in this effort. So relying on your continued support will allow us to be able to do that and make a difference, not only for the folks that we are caring for here, but for Americans everywhere. So again, please welcome home Kathy Greenlee. All right, Kumar, I think we're ready for the closing. Come on up. Kumar Atharajan, a member of our board and the chair of our Resource Development Committee. Thanks for coming.
Thanks, John.
Thank you. You can use that.
Thanks, Kathy.
Thank you.